Welcome to today's case study training session for Circle of Care nurses entitled Talking to Patients and Their Care Partners About Their Motor Fluctuations. Joining me today on the training call is Amy Miller. Amy serves as the Circle of Care nurse liaison for the Eastern region of the U.S. And my name is Jean Hubble. I'm Senior Medical Director at U.S. WorldMeds. We're going to start with a case that Amy actually encountered recently, and we'll use that to springboard to a discussion about how best to understand the Parkinson patient, their levodopa response, and motor fluctuations. I'll turn it over to you, Amy, and to the first slide.
Thank you, Jean. A little bit of background on this patient. He was or is a 75-year-old male who had been prescribed Apokyn for motor fluctuation. He has been diagnosed with Parkinson's for 9 years and has a strong care partner support. The prescriber is a new prescriber who has never written for Apokyn before. A relatively new nurse scheduled a pre-initiation education. She scheduled that for a time that both the patient and the spouse were present for the education. The COC nurse arrives at the patient's home for the education. She describes the purpose of Apokyn and asks the following questions. She asks the patient, "Do you take an oral levodopa?" The patient responded, "Yes." "How many times a day?" 4. "Does it take longer to work sometimes?" "Yes." "Does it wear off sometimes?" "Yes." "Do you have off times?" "Yes." "How many times a day are you off?" The patient responded, "Sometimes once." "Are you sometimes slower in the morning?" "Yes." "Do you have difficulty with walking?" "Yes." All of these questions are short and closed-ended that led the nurse and the patient to believe that the patient does have motor fluctuations, possibly related to dose wearing off or dose failure. These answers in themselves seemingly make the patient a potential Apokyn candidate. Asking the patient and care partner these questions can be very misleading and miss the true assessment of the patient's motor fluctuations. We are assuming in this case that the patient's understanding the same meaning of off that we have. Inspector Gadget comes in and asks the patient and care partner open-ended questions that were invaluable to our assessment of the true motor fluctuations. The nurse then introduces herself at the education visit and asks the patient to tell her why he thinks Dr. Smith prescribed Apokyn. His answer was that Dr. Smith said it would help his weak and wobblies. That's where our investigation begins. Tell me about those weak and wobblies. What happens? The patient responded that sometimes when he stood up, he was weak and couldn't take steps right away. We then asked, how often do the weak and wobblies happen? Once or twice a week was the patient's response. Doing a little bit more, we're asking if the patient notices if they happen when they're close to a dose of Sinemet. The patient responded that it happens randomly. We then ask how long the weak and wobblies last and what makes them go away. Patient responded that his weak and wobblies lasted 3 to 4 minutes and he just sits back down and starts again. We ask what else happens during those times. Nothing. I just feel shaky on my feet for a few minutes. We then go into more specific motor fluctuation questions and ask the patient if he has stiffness, tremors, or any difficulty speaking when his weak and wobblies are happening. That is a closed-ended statement, but it does give answer to motor fluctuations when he says no. We ask then, do the weak and wobblies happen more before his next dose of Sinemet is due? No. Tell me what getting out of bed looks like in the morning and starting your day. What does that look like? He responded that sometimes he falls asleep in the chair. When he does, he can't get up as easily because his back hurts. That doesn't happen when he sleeps in bed, which answers the morning akinesia questions. Do you have, the closed-ended question was, do you sometimes have trouble getting going in the morning? He originally answered yes, but if asking the question as Inspector Gadget, we're finding that he's not slow in the morning due to lack of levodopa, but that he sometimes falls asleep in the chair and his back hurts. The nurse does a little bit more digging to be sure. We ask what time does he normally get up, most days around 7. We ask when he takes his first dose of Sinemet, around 9 o'clock with his breakfast. We then again ask what do mornings look like. He gets up, takes a shower, and gets dressed. He usually takes the dog for a walk and reads the newspaper. Then he eats his breakfast. From that, we're seeing that he is doing all of those things 2 hours after he wakes up when he's taking his first dose of Sinemet. We ask about the first dose of Sinemet if he's able to move better when he takes it. He doesn't notice being able to move any better. He feels the same as before he takes it. In summary of all of those questions, we're asking him how he thinks Apokyn is going to help him. Jean, can you go? Sorry. The doctor said it will make his weak and wobblies better. How long do they usually last again? We're reconfirming the patient's answer, sometimes a few seconds. A bad case of the weak and wobblies will last 3 to 4 minutes. This type of questioning definitely presents a different picture of what is happening with the patient. Both the patient and the care partner are in agreement that this is usually the daily picture. The follow-up and open-ended questions gives a very different picture of the appropriateness of this patient selection. Based on questioning during the education visit, this patient is not having true motor fluctuations and is not a candidate for Apokyn. Follow-up communication then needs to happen with provider, and additional education for patient selection should occur.
That's a great case, Amy. Thank you so much for presenting it. It really does highlight a few features of the importance of having a good open-ended discussion with the Parkinson patient and their care partner when they're available, because while motor fluctuations with long-term levodopa therapy are common, nevertheless, it is not always the most disabling or disconcerting feature of a patient's Parkinson's disease. So let me pick up on that a little bit further, and let's even examine the literature on this topic. Not all problems that a Parkinson patient faces are true motor fluctuations, and that was exemplified by the case Amy just discussed. However, motor fluctuations are a common complication of long-term levodopa therapy, and those too can have a major impact on patients' lives. And let's look at that evidence. These are the results of a survey conducted by the Michael J. Fox Research Foundation, and they asked over 3,000 Parkinson patients as a part of this web-based survey to assess their experience with OFF episodes. In this particular survey, more than 90% of patients reported that they had had at least one OFF episode per day. Many, the majority of the respondents, had off time accumulating up to 2 or more hours of the waking day. And in fact, a smaller percentage, 20%, were even off for more than 4 hours over the course of a waking day. Many of the respondents said these off episodes were moderate to severe and actually caused them to avoid or stop activities that they could otherwise perform when their levodopa was working well and they were on. The average overall disability rating, self-rating, that the patients gave themselves was almost twice when they were describing themselves in the off state as compared to on. So this is in contrast to the patient just reported by Amy, and shows you the variety of Parkinson's disease and their response to levodopa. But let's move then on to off episodes. This is now looking at 3 different long-term studies in which levodopa-treated patients were systematically assessed over many years' time. If you look at the box at the far left, in that study, patients on levodopa were studied over 4 to 6 years' time, and by the end of that assessment period, approximately 40% of the patients were suffering from off episodes, times where their levodopa effects either wore off too soon or a dose of levodopa did not kick in quickly. Some doses of levodopa don't kick in at all. If you look at the middle box, now we're talking patients 9 to 10 years duration of treatment with levodopa. Now we're up to a majority, over approximately 70% of these patients had motor fluctuations or off episodes. And finally, when you focus on young onset patients, patients whose onset of Parkinson's was before age 40 years, and having been on levodopa therapy for 5 or more years, now we're talking virtually all patients develop these fluctuating responses. And of course, Michael J. Fox would be an example of that. Most Parkinson's specialists would say he had nearly a 100% risk of developing motor fluctuations. It goes to say, without any additional evidence, that motor fluctuations or these off episodes have a big impact on motor function, because if you're off and you have severe tremor, slowness, stiffness, then obviously you have great difficulties with mobility. And this is echoed in this study by Dr. Chapuis and his colleagues. So you see in the very top line all the various forms of off episodes or motor fluctuations had a great impact on mobility. But I think it's also important to understand what that translates into in the patient's day-to-day life. Look at activities of daily living on line 2. Again, greatly impacted all the way across all forms of off episodes. Emotional well-being can be impacted by off episodes. It's also very stigmatizing, meaning that patients can't predict when they're going to be on or off and are embarrassed to go out in public. And so there are some patients that are virtually homebound except for their doctor office visits or other imperative outings into the public. It can affect an individual's ability to think clearly and, most importantly, to communicate to others. And, of course, it can be very uncomfortable as well. So the impact on patients' day-to-day life, quality of life, even their mental and emotional well-being can be impacted by off episodes or levodopa fluctuations. Apokyn only can help levodopa fluctuations or so-called off episodes. It does not help other features of Parkinson's disease. I often say that you can think of Apokyn as working like levodopa in a syringe, and so of course it won't help any Parkinson's symptoms that are refractory or unresponsive to levodopa. The flip side of that coin, Apokyn nearly is always effective in treating true motor fluctuations or off episodes, providing on-demand levodopa-like response within minutes. Now let's look at that evidence. This first from a placebo-controlled study published by Dr. Ron Pfeiffer several years ago. And this compares patients on Apokyn versus lookalike placebo doses. And you can see that there's a great improvement in their Parkinson's disease rating scale motor scores. Even within 10 minutes, patients clearly separate from placebo when using Apokyn. And then you can see the waning response, so that by 90 minutes, the patient's back to baseline. But this shows you can get a true levodopa-like response very quickly. So that's the rapidity of how fast Apokyn works compared to levodopa. But how reliably does it work? This is a study published by Dr. Richard Dewey several years ago, and it compared on an outpatient basis patients using Apokyn to abort or treat their off episodes versus placebo. Let's just focus on the very top line because this was the primary outcome in this study. The primary outcome looked at patients' home diaries, and they recorded when they were having on versus off time. And every time they took an injection, not knowing if it was active apomorphine or placebo. And you can see that patients, when they took active drug, 95% of the time they self-reported that they were successful in stopping or flipping that off episode into on time. And for those of you that have done other researcher work in with subjective rating scales like this, like a home motor diary, 95% success really is as close as you can get to 100% response rate. You can note here that the placebo, a very small percent of the placebo off episodes did respond to placebo. How could that be? Well, do remember that these were all patients who are taking all their usual Parkinson drugs, just like the patients that you see every day in your work as a Circle of Care nurse. So eventually, their medicines, their oral medicines, do take hold, and they eventually turn back on. It's just that they don't always do that predictably with their usual Parkinson medications, including levodopa. So to summarize then, who is the good candidate for APOKYN versus the less than ideal candidate? First, on the left side, looking at selection criteria for good candidates. Good candidate for APOKYN is a patient who is on levodopa and does respond to levodopa therapy, but they are experiencing off episodes despite add-on conventional therapies and their routine use of levodopa. So levodopa works, and when it works for them, they're able to function fairly well, but when levodopa fails to work reliably for them, they have many difficulties in motor function and day-to-day activities. As Amy demonstrated in her open-ended interview with the patient, it's always good to be able to put day-to-day life into the patient's own words and identify their goals, their treatment goals or activities. In other words, their treatment goals or activities that they are able to engage in when their levodopa works and they are on, because that then will help once they're on APOKYN therapy to understand if they're on an ideal dose and are they getting that full on so that they can accomplish those crucial day-to-day activities. That can be anywhere from someone who's working, maybe even working full or part-time. And so, of course, it's very important for them to be able to function well, both physically and mentally, and have a dependable medicine to allow them to function. That can also be a retired but active patient, perhaps a retired individual who likes to golf or have other recreational activities or likes to look after the grandkids, etc. It could even be a much more sedentary patient, but yet someone who is able to assist in their activities of daily living as long as their levodopa is working and they're on, because APOKYN can afford them that reliable on. It's also important to have either fairly good cognitive function on part of the patient or an able care partner, because that decision needs to be made. Is this the time to give the APOKYN injection? Who's less than ideal? Well, patients who have very significant cognitive impairment or other neuropsychiatric problems that complicate their Parkinson's care. And that's because, again, it can be very hard to tell when they need APOKYN, and also it can be difficult to tell if APOKYN is making these neuropsychiatric or cognitive problems worse. Patients who have very troublesome dyskinesia. So if you think about Michael J. Fox, when you see him on television, he usually has mild to moderate dyskinesia or wiggly movements. That's due to too much Parkinson medication in his brain at those minutes or times. If you give such a patient APOKYN, they may have very severe dyskinesia. So if they already have a lot of very troublesome dyskinesia so that they can barely function because of these involuntary movements, it can be very difficult to titrate to the right dose of APOKYN. Better in those cases usually for the doctor to make some decrements in their other Parkinson medications before you introduce APOKYN for their off episodes. Also, a less than ideal candidate can be patients who have very significant comorbidities that complicate their Parkinson's disease care. Say, for example, they have very significant heart disease, severe obstructive lung disease, perhaps even have cancer or other, significant medical condition that is limiting life expectancy and causing current significant morbidity. In those instances, it's usually most of their health care efforts are being directed at these other medical problems, and motor fluctuations are not the main target of their day-to-day medical care, and therefore introducing a PRN medication like Apokyn can make it very difficult to judge what's the other medical problems versus potential side effects or benefits of Apokyn. Again, everything in the right column is not contraindications for the use of Apokyn. It's more of a yellow light, a caution light to kind of think through, is Apokyn really right for this individual? So let's start summarizing, and I'll take this first slide. Some of the take-home points: it's imperative to determine if a patient who is a potential candidate for Apokyn has true levodopa fluctuations. Exposing an inappropriate patient to Apokyn can only pose risk or potential side effects and offers no hope, no potential benefit for that patient. So that only can, again, cause side effects for that patient and no upside or benefit for this patient, who, of course, are very often quite desperate for improved medical care. The flip side, again, though, is for the appropriate patient, the patient who has levodopa motor fluctuations, we can anticipate that they will almost always respond to Apokyn, assuming that they can tolerate the drug. Amy, if I could turn the summary back over then to you about that important conversation with the patient and their care partner.
Sure, Jean. So some of the take-home points from this visit and the case study and what Jean has discussed, using open-ended questions presents good pictures of what's happening with the patient's day. Focusing on levodopa, its timing, and their response to the levodopa to understand motor fluctuations based on dose failure or dose delay. Not talking just about the symptoms of those things, but about how they affect their activities of daily living when levodopa is working versus when it's not working. Can you dress yourself, walk without fear of falling? The patient that we looked at, he was getting up, getting dressed, taking a shower, taking the dog for a walk. He was doing all of those things before his first dose of levodopa. We assumed from the closed-ended questions that he was having motor fluctuations. We also assumed that he knew what we were talking about when we asked about off episodes. It was a very different picture when we looked at how he lives and does his daily activities. Drawing on care partners' observations, if available, sometimes they have a much better picture of what's happening than the patients themselves, and or using it to confirm what the patient is saying. So at the end of the call or visit, it's important to summarize what you've learned before concluding the call or the visit. Saying to the patient, what I think I've heard you say today was that your levodopa doesn't dependably kick in for you, especially first thing in the morning. Is that correct? And if that's so, it sounds like a time of day that we should target with Apokyn, correct? So that would be, if you had a good Apokyn candidate, those are things that you would want to talk about and help the patient understand when they would use Apokyn. In the case of our patient that we did the case study on, summarizing that the patient had weak and wobblies that lasted anywhere from seconds to a most severe case of 3 to 4 minutes. We talked through that and how Apokyn works. It takes 15 minutes. So how is Apokyn going to help the weak and wobblies if they're lasting only for 3 to 4 minutes? Just reconfirm with the patient, making sure we didn't miss anything. And after that summary, having the whole picture, there was a conversation that happened with the provider to talk about good patient candidates versus less than ideal candidates, and how APOKYN would directly actually not work for this patient because he wasn't truly having motor fluctuations related to his levodopa doses.
That's excellent, Amy. So I'll conclude then by firstly thanking Amy Miller for preparing this case study on the importance of that conversation with patients and care partners on motor fluctuations and the potential role of APOKYN. And I urge all of you to, if you have additional questions or comments on this topic, please take those to your regional nurse liaison, and we look forward to further case studies in the future. Thanks all.
Thank you, Jean.